Everyone, I think we're ready to go. Mike, I think we were designated one of the most connected universities in the country. Demonstrated here, but I just want to say a few words. It's indeed an honor and pleasure to have Mike Cookson here. Mike trained at Sloan Kettering about 10 years after I left. And as a fellow, I was hearing about Mike Cookson, and then over the next, I won't say how many years, I've heard more and more. And Mike is remarkable in many ways. And Seema is going to introduce him formally all the awards he thinks he's done in urology, but he's demonstrated that he can be a leader across fields in oncology. You'll see the work he's done in prostate cancer, early and late stage disease. So he does lead the panel on castrate-resistant prostate cancer. I think I think it's remarkable for urologists in doing that. And then, of course, your contributions for bladder cancer. We're incredibly grateful for you to be here, especially when getting here was not easy. But thank you very much for being here. And Seema's going to give the formal introduction.
Okay, I'm going to borrow your mic.
I don't think my voice is loud enough. Maybe it is. So it's my pleasure to welcome Dr. Cookson. He's a professor and chairman of the Department of Urology and the Donald D. Albers Endowed Chair in Urology at University of Oklahoma. Peter gave a little of his background. He's authored over 240 peer-reviewed journal publications and more than 30 chapters of various textbooks, and is nationally recognized for his contributions to urologic oncology. Prior to his chairmanship in Oklahoma, he was at Vanderbilt and served as the vice chair as well as the fellowship director for urologic oncology. And he's devoted much of his academic career to the management of patients with urologic cancers, but has a really strong emphasis on clinical guidelines, education, and evidence-based medicine. This is exemplified by his roles with the AUA across the bladder and prostate guideline committees, as Peter pointed out. As well as with the ABU as a committee member and examiner. He's also the co-founder of the OCAT, which is the Oncology Knowledge Assessment Test, which by the SUO is a mandated examination, and he's also past president of the SUO. So for these contributions, he has received many awards, including the Distinguished Service Award from the Society of Urologic Oncology, as well as the AUA Presidential Citation for Outstanding Service. So personally for me, Dr. Cookson has been a fantastic sponsor and mentor, particularly within the SUO. And I've had the pleasure of working with him across various committees and projects. And in particular, I want to convey our appreciation for his support on one of our major endeavors, which is the WUO, or Women in Urologic Oncology, to increase recruitment of women to our field. And without his support and sponsorship of that initiative, we wouldn't have been able to make it possible. So I'm thrilled he can be here with us today. And without further ado, we welcome Dr. Cookson.
Thank you. Thank you so much. It is truly an honor to be here and a privilege. I appreciate and know how hard it is just to take any 5 minutes out of your time for anything. So apologize for this AV glitch, but really happy to be here. I'm going to talk a little bit about improving outcomes in prostate cancer in a multidisciplinary model and look into the advanced prostate cancer and sort of show you where I think we're going with localized prostate cancer, even high risk patients. Before I do that, hopefully we'll be able to bring up my slides. I just wanted to recognize that the presence of UCSF in the urologic world is quite impressive, and the past, present, and future are all represented here. And giving the Tanago lecture and understanding his 20 years of chairmanship and his large impact over really probably 50 years is completely unbelievable and outstanding. And then turning the reins over to Dr. Carroll and the advancements, the team and the team science and the diversity and all the things that he's been able to establish here is even more impactful. And then, the future, I got to spend the day with the residents yesterday and had a lot of fun. They always teach me more than I'll ever be able to show them, but we had fun doing it as well. And looking forward to going out on a little casual hike in the woods later today. But they're so happy to be here, and they're so excited about their position. And I asked them, like, what do you like best about this place? And they said it's the people and it's the relationships and it's that culture that you have. And so you have something very special here. And I didn't know this, you all know this, but they said it's like, you never leave type of situation here, the abbreviation for UCSF. So, anyway, thank you so much for inviting me. And it's an honor and a privilege to be able to speak today. So what I want to talk about is first kind of the multidisciplinary care model. I don't know if we have any non-urologists here in our audience today, but the multidisciplinary approach is becoming extremely popular, increasing. Originally was sort of just at very select centers and NCI designated comprehensive cancer centers, but it's certainly permeating into the large group private practices and even the community cancer centers. All have that shared goal to make available to all our patients with urologic cancer multiple options, different treatments, and look at it from a different aspects. This was a shameless plug for Kelly Stratton, one of our faculty that he put together with Alicia Morgans. It just came out, but it's a textbook on multidisciplinary cancer care. And if you don't have it, you might want to look into it. Um, we know that for all areas of urologic oncology, there's been a credible amount of advancements, and we see it in prostate, bladder, kidney. So it's not specific for prostate, although that's what my talk is today. And bringing together experts from all these different disciplines has resulted in improvement in care. So that new standard of care for GU oncology really is patient-centered. We all know that. It involves that shared decision making, and they don't make the right decisions if we don't present those to them. And of course, in many circumstances, there are multiple types of treatments and combination treatments that can be offered. And so, really, it's that multidisciplinary approach that allows for that. Prostate cancer is ideally positioned for this for many reasons. And this multi-D model, in the interest of time, don't have time to show everything, but I think we can show that in most circumstances, there's more adherence to evidence-based medicine and guidelines where possible, broadens the treatment options, increases enrollment in clinical trials. That's a big area of emphasis. Even in our little Oklahoma Cancer Center, we're the leading academic. We enroll more patients in the large group academic cooperative group trials than any place in the country. And urology is the leader within our center. So we really buy into this and believe in it. And so it works if you have the right model. And then there's also this component of regret and treatments if patients don't feel they're properly counseled, and there've been less regret and indecision with use of these multi-care models. What are the members of the team? Used to be pretty simple. You need a urologist, a radiation oncologist, you need a medical oncologist, but you need a lot more than that really to do it right. And so navigation is really important. It can be a nurse navigator or a very skilled person who understands some of the complexities. There's, of course, financial navigation, which as surgeons and urologists sometimes we overlook, but it's a very important component of it. But coordinating who needs those multiple visits, how those visits are going to play out, not just the initial visit, but everything that happens after that. It's really hard for patients to keep track. And so if you have that type of navigation, it's really helpful to them. And then I couldn't do my practice without advanced practice providers. And I don't know if there's any of those in the room, but nurse practitioners, PAs are invaluable to us in helping. And then there's a whole lot of other things that are getting added on here. So you probably have all these in your center, cardio oncology, lots of, I heard you have like a genetic SWAT team that helps them and different things like that. But they're, the imaging, explosion, nuclear medicine, nutrition, psychology, psychiatrists, counselors. These are all, everything you can add to that when the patient needs it is going to be an additional thing that really helps improve their care and really adds value. So the pros of it are listed here, and there's multiple pros, but it definitely should improve the outcome of these patients. It gives your program visibility. It's not easy for somebody out in anywhere USA to know where should I go for my cancer care. How can I find that out? And developing these type of centers of excellence and multidisciplinary care models really can be a beacon for that. It facilitates not just for the patient, but for their families. High satisfaction, lots of retention. Usually once they come, they see the value you add. They know the difference between what they were doing and what they're going to get, and they continue to stay with you. We talked about regret. Certainly facilitates education, learning, fellows, residents, even old attendings. So everybody learns and gets better from this. Clinical trial discussions really don't take place in a vacuum, and you have to anticipate it. You have to have that clinical trials team. But first, you have to identify that the patient might be a candidate for it and introduce that to them, and that can take time. So this whole process works, but it takes an army to do it. And it's not without cost, right? So sometimes it takes more time. It's inconvenient. It could be more costly. They have multiple visits. They get multiple doctor bills. Um, there are reimbursement issues and billing issues. There's logistics, is it the same day for all of them or do they come back on different days? Depends on how far they travel. That gets back to that navigator component, knowing like they live locally, they can easily see Dr. X, Y, and Z on different days, but they get that care. So all those things are important and they're different in every center and every location. So there's not a one size fits all on these models. This is one of the reasons we have this is because we have so many treatment options now for patients. Used to be castration resistance, and Dr. Carroll's exactly right. When they first came to me from the guidelines, which Ian Thompson got me on for localized disease when I was a young, um, they said, let's do an advanced prostate cancer one. And at the time they did it, that we had nothing. We had no randomized trials. We had no medications. We didn't even have docetaxel. And so I was like, no, we're going to do, castration resistance. Maybe we have a few trials there. We don't have anything for like the most common thing we treat, which is advanced prostate cancer metastatic. That came over the next decade. So then we began to fold that back. So you'll see that theme, but there's probably 13, 14 different treatment options listed here, new ones coming out every day. So ASCO is happening right now. Some immune therapies are trying to work their way into earlier disease states. But when you look at all the options we have, you have to add on those multidisciplinary teams because I don't administer radium 223. I don't give chemotherapy, but I know when it's needed and we work with them. We do administer a lot of the oral agents and we certainly are involved in all the hormonal therapy. So you become their diagnostician, you become their confidant, their friend. In America, many patients don't just present de novo with metastatic disease, they progress from treatments. We don't have great treatments for high risk localized disease. You do their surgery, then they relapse, then they have, so you're their constant contact, and then you can use that as an ability to sort of give them those extra visits that they need and they trust you. But it's definitely layered on that team approach. Guidelines are really helpful, and especially if it's not a disease that you live in every day, so it can really be important. And so it's been said that we're sort of drowning in information but starving for knowledge. And one of the things that the guidelines panel does is they take they cast this broad net and look at thousands of articles, try to condense it down to a couple hundred, pull it together. They do put cut points on it, and the minute they do that, that means another randomized trial is going to get published. So you have to constantly update them and guard them. And that's one of the deficiencies, if you will, of the AUA. So the NCN just kind of compendiums. If something gets FDA approved, they sort of stick it in a spot. It doesn't always tell you how to use it or whether it's got good evidence or how well the study was performing, but they'll put it in. AUA is more cautious. They usually want to analyze the data, grade the data, and synthesize it. And so it's made it a little more difficult to be, right timely every 3 months, every 6 months. And there's lots of different things that we need guidelines on, not just cancer products. So they're expensive and costly, at least for all the work that goes on behind the scenes. This AUA advanced prostate guideline was, again, taking the castration resistance and then bringing it back. And so it covered everything from biochemical recurrence through newly diagnosed metastatic and then non-metastatic CRPC and CRPC. So it's a pretty inclusive guideline, had about 38 statements. Many of you know, but the grading system is used in this. And so whenever you look at a recommendation, you can look and say, what's the strength of that? And lots of pharma argue, oh, you picked on me, you didn't give me the grade A rating. But if you look at their study, it was compared to water, or they didn't use the standard of care when the control group, or the study effect was small because the number was pretty tiny. So there is some nuance to the statistical component of it. But nevertheless, you can quickly look and say, well, how important is that? And then, of course, there's things that don't fit into randomized clinical trials, and those are more clinical opinions and expert opinions. And so that's also in the guidelines where it's important, but it's clearly stated that that's exactly where that lands. So these are sort of the overview of what we're going to talk a little bit about. It's probably a given, but a primary tissue diagnosis is preferred. I know every year we see patients that are already on treatments. They never had a prostate biopsy, and it's unusual, but it happens. And sometimes you learn a lot from the biopsy itself. So it's a given that you need to get a biopsy and a tissue diagnosis, unless it's just an emergency where you have to start treatment for, say, cord compression or something like that. But where possible. And then, of course, you want to make sure you have the right diagnosis. Once you have a diagnosis, of course, you're going to stage them, and you have to consider the same things we do on the early end for localized disease. What's their life expectancy? What are their comorbidities? What are their preferences? It's really important. We always assume that patients' preference for treatment is going to be similar to ours, and it's not always that case. And so, especially when it comes to a disease that has a lot of impact on quality of life. And so, that's an important component. Introduce the multidisciplinary care model. We need to talk about symptoms. I mean, residents presented me a case yesterday where a gentleman was very symptomatic at his presentation. And so that kind of set the stage. Patients can need pain medication, pain management. We're taught, the opioid crisis, don't write too many of these pain medicines. Well, then you need help with it. And so then you have a pain management team, a palliative care team. Some people historically have thought, palliative care is the place you go when you're sort of hospice, but it's not. I mean, there's palliative care and pain control and pain management that occurs when patients have long life expectancies. So that's an important component. Biochemical recurrence. We need to do more work there. It's a pretty weak data poor zone. But sorry about that. The recommendation here is that you follow these patients. They've failed local therapies. This guideline was an adjuvant radiation, early salvage radiation. This assumed that they'd exhausted their local therapies, and so you're following them along, and you do periodic imaging. This is going to get updated, obviously, because conventional imaging is still standard of care. But obviously, with the PET imaging now, we should include that. And certainly, that's been around for a while. But as it stands currently, you recommend imaging. You can certainly recommend PET imaging, and some insurance companies will balk on the initial recommendation, but most are now coming along. And so, we've had an evolution from some real specific type of PET scans to more advanced. You all know, I mean, at one of the centers for development of the PSMA scan, and that's great because I don't have to send my patients here or LA anymore. So that's wonderful, and that seems to be what we're working on currently. Is the PSMA is sort of the gold standard for PET imaging, not only just approved for biochemical recurrence like the Oxyman scan was, but also for patients for surveying for metastatic and high risk disease. So that will be coming in our addendum and change to the guidelines. But now we know that in biochemical recurrent patients, we can find disease in very small areas where we never could see it before. And so we don't have to panic or shotgun approach them if we have a way to identify the extent of the disease. It is still recommended, though, if the patient has a slowly rising biochemical recurrence, no evidence of metastatic disease, that you should at least consider observation for those patients, because there are natural history studies that show that not all those patients have a rapid demise, and we know that treatments have side effects. So it's an important consideration that not every patient with a PSA recurrence has to have an immediate treatment. If you do initiate androgen deprivation therapy because of maybe low volume metastatic sites or nodal sites or rapid rise in their PSA, then these patients may be the ones that are appropriate for consideration of intermittent therapy. And this was one of the few studies that was done after radiation failure patients that showed a non-inferiority, or essentially an equivalence to their overall survival when you looked at intermittent versus continuous therapy in these patients. And of course, there are some improvements in their quality of life when they're off therapy. So this would be probably the one area where intermittent therapy may be unacceptable. So we'll move on to a patient that has a more advanced disease, which is kind of a case. So 65-year-old gentleman who presents, he's got some mild lower urinary tract symptoms and an abnormal exam. His PSA is 75. He has a Gleason score 8, grade group 4, multifocal on his testing. And so, what next for this gentleman? Of course, we need to assess the extent of his metastatic burden. Again, now you can insert a PET scan if you'd like with a PSMA. Conventional imaging is what most of the data has been derived from so far, but at a minimum, you would do a bone scan and a CT with contrast of the chest, abdomen, pelvis, or substitute that PET. It's important to consider the volume of their cancer. We've known since early SWOG studies in the 80s that the extent of their disease kind of predicts response to therapy. And so dividing patients up into some sort of low volume, high volume makes sense. And certainly some of the clinical trials, the response to the therapy was impacted by that. And so we have adapted it's not perfect, but a charted definition, which was a study that looked at number of sites of metastatic burden, and so 4 or more, and at least in the bone, and then 1 outside of the axial skeleton of the pelvis, or involvement of visceral disease gives you the definition of high volume disease. And you'll see why that's important later, but you're staging them and then you're kind of sorting them to understand what is the extent of their disease. Genetic testing sounds like you guys are all on board with that, but it wasn't very long ago that urologists didn't even think about ordering a genetic test on somebody for their germline unless they told you they had 7 brothers or uncles and fathers that had it. But now we're picking up breast cancer in the history, lung cancer, colon cancer, ovarian cancer. So our antennas up more in addition to the usual family history of prostate cancer. And germline testing, while not always fruitful, maybe 10% of patients with newly diagnosed metastatic disease will harbor one of these DNA repair mismatch. And so you'll catch them if you do that. Of course, we talked about this with the residents yesterday, but it involves, if you don't have genetic counseling, you do here, but there's a lot of cascade effect to this genetic testing, and you have to be counseling them about that and their implications for their family members. Because remember, as we sit here right this moment, we don't have an extra treatment to add on to their newly diagnosed metastatic disease based on germline. They might be eligible for a clinical trial, but it's going to potentially impact them later in their treatment, and it also will have an impact potentially on their families. So the counseling part shouldn't be discounted. In this scenario, this patient had some small volume retroperitoneal lymph nodes on conventional imaging and then a bone scan. This was before we had PET, so he had low volume metastatic disease. So the question would be newly diagnosed metastatic, low volume, what are his treatment options? So we all know that androgen deprivation therapy, LHRH agonists or antagonists, are both appropriate starting points for that. And believe it or not, that probably 40-50% of the United States still stops at that. They just give hormonal therapy. They don't add anything to it. And we're really trying to make sure that people consider adding additional therapy. And so that's what this next bullet point is about, is the options of adding either abiraterone, apalutamide, enzalutamide, so androgen targeted therapy where there's data, or chemotherapy, and that's docetaxel, which is the only one that really has approval for that newly diagnosed metastatic. So just kind of compartmentalize them. You can do chemo hormonal therapy. You can do maximum androgen ablation, which I consider any of those AR targeted therapies, plus ADT. And now in the last year, there's been an emergence of people sometimes buzzworded as treatment intensification, but kind of thought we were already intensifying when we added this additional stuff. But it's a triple therapy, essentially, where you can add to the ADT and docetaxel either abiraterone or darolutamide, which have the 2 trials, and I'll show you those in a minute. The charted study, which was done now a few years ago, was a pretty big advancement, because when we first came out with castration resistance, there was a 3-month survival advantage to giving chemo, and all the urologists said that's not very much. We're not going to get much out of that. Not too excited. But when it got moved back into an earlier disease state and newly diagnosed metastatic disease, there was potential for more bang for your buck, if you will. They did divide these patients up. That's where you hear that charted definition for high or low volume as listed here. And it was sort of already assigned before the study. So it had the potential to subset out response. And so what they found was overall there was a significant response, but this time it wasn't 3 months, it was a year of overall survival advantage for these patients just by adding docetaxel. So that was really amazing, because you think about all the things that we've offered men for prostate cancer since the Huggins discovery of hormonal ablation, and there was really hardly any breakthroughs. And now we had something that was going to add on average a year or more of additional length of life. And When they subsetted it, what they found was that for all patients, there was a response, but the best response in the US charted study was in those patients that were defined as high volume. And there, the difference was 18 months. So that's a big deal. And so most patients who present, if they have the possibility and are capable of getting chemotherapy with high volume, newly diagnosed metastatic disease, are offered docetaxel chemotherapy as a standard of care. In the US study for the low volume patients, they really didn't see much of a benefit. This just got updated, or it's going to be updated this week at ASCO. It's got 8 years of good follow up, and it didn't change anything. So the high volume disease, and most of these patients are progressors through local other treatments. That becomes important when you look at the international study, which comes next. So the Stampede study was a very similar trial design. They had ADT plus docetaxel or ADT alone. And just like the US charted study, there was a significant improvement in their outcome, significant reduction in death from prostate cancer by adding chemotherapy. What I don't have time for on this slide was about 75–80%, I think, of the European study present with metastatic disease, and they actually had benefit in low and high volume patients using docetaxel, and they don't prescribed to the theory that you need high volume disease to get chemo. In fact, they've published some subsequent follow-up where their low volume patients got the best response. So there's some more to be learned besides just dividing patients up on the volume of their metastatic presentation, as well as whether they're de novo or present through progression of disease. But there's probably differences that explain why docetaxel appeared to respond differently based on very similar trial designs. In addition to the docetaxel, then we talked about the use of these oral agents, these androgen receptor treatments. They were again introduced in the castration-resistant model, where they added a little benefit, I'll show you those later, but like 6 months type of benefit. Here, they were moved up into newly diagnosed metastatic disease, and the use of abiraterone with prednisone combined with ADT compared to ADT alone was a highly significant improvement in their outcome. So that was a big advancement. And there were two studies, and the Stampede was the second study, but they had kind of mirror image results with survival benefit and adding that additional therapy. So it might seem common now, but in the old days, we didn't really understand that you could get more than just the benefit of the LHRH agonist in treatment of their androgen suppression. An additional study now with an AR targeted therapy, apalutamide, also, this was the Titan study, showed a survival benefit by adding an androgen a pill to their mix. So we used to use Casodex and flutamide and those type of medications. They're probably maybe a tenth as potent as these, and they don't work quite the same. So it was a surprise really to get that much of a benefit from using these, but certainly apalutamide and enzalutamide both have a very important role in treatment of newly diagnosed metastatic disease. There were two studies looking at enzalutamide. The first one was really just looking at like radiographic progression-free survival, and of course they were highly significant there. The second one looked at survival overall, and again had significant improvement in overall survival. So apalutamide and enzalutamide work similarly. Abiraterone works differently. I'll show you those mechanisms of action. But the idea is that you continue to put pressure on the androgen axis, and the cancer responds and patient benefits. Over the last year, this triplet therapy, now there's lots of things coming out on that. So this was the piece one study design, and you don't have to worry about all the arms of the study design because they were looking at the value of radiation, the value of adding abiraterone with radiation. But the bottom line was that in the arm that compared abiraterone to docetaxel ADT or no abiraterone, they had a significant radiographic progression-free and overall survival benefit by adding abiraterone. So now you have three drugs or three treatments added, and it's starting to sound a little more like testicular cancer. You're starting to use combination therapies to try and drive it back. These were pretty significant benefits. I think it added like 2 more years of additional cancer control and benefit to these patients. And so these are not just like 3 months, 2 months. These are pretty significant advancements. And that's just a subset population. But at the bottom there, you can see both low and high volume, as continuing to use that charted definition, did well. So there wasn't like you can't just say, well, your lower volume disease, maybe you don't deserve to get this triple therapy. although it does come at a cost and there are side effects to it, all these medications layer on not just financial toxicity, but they layer on additional hypertension, electrolyte imbalances, liver dysfunction. So there is more monitoring to be done and there's more cost to be paid. So I don't think we have it completely figured out as to who gets the 3 versus who gets the 1, but definitely that's a possibility that you could get 3 treatments now on newly diagnosed metastatic disease. And then the second triplet therapy, if you will, is the Aronson study, and that added darolutamide to the ADT and docetaxel as compared to placebo. So in the Aronson study, all they did was add another drug to the mix, and again had a highly significant benefit, overall survival benefit. You can see it here. And unlike the abiraterone, there wasn't as much toxicity to it. So there's maybe a little better treatment. You don't have to do as much monitoring. You still have to monitor for the docetaxel, the usual chemotherapeutic labs, but you don't have liver function abnormalities, potassium abnormalities, things like that. So again, darolutamide has that indication. The other 2 agents that are similar do not have studies in this published studies in this space yet. This is some of the stuff from Charted, but it just suggests that your PSA response tells you something about how you're doing. And so I put this up there just to suggest, sometimes you treat patients and they get a super response. So you give them docetaxel, combine it with their ADT, and their PSA nators down to something almost undetectable, 0.2 in this cut point, and they get a very durable response. And so maybe one way to select that triple therapy would be looking at PSA response and objectively adding the layering in that third treatment when you see that they're not responding. And certainly if they don't go down to less than 4, that's a poor prognostic indicator, and you would want to be strongly considering adding additional therapy. So in this case, which predated these triple therapies, our patient was placed on LHRH plus abiraterone and prednisone. He had a good response. He had side effects that you would, expect for the treatment that he was under, and he remains on bone health, which is basically exercise, vitamins, avoiding smoking cessation, and alcohol moderation. But he didn't have to be on any bone targeted therapy. What about treatment of his primary, though? Let's say you have a gentleman that's never had his prostate treated. He presents with metastatic disease. Should we add therapy? Should we do surgery? There were a couple of studies in this space, but the Stampede study had the most robust data. So I'll just briefly go over that. Overall, for all comers, it was only a little bit of PSA failure-free survival type stuff, not overall survival. So that's for all comers, high and low volume. But if you took the patients who were subsetted out with low volume metastatic burden, so these oligometastatic patients, they did show significant benefit in terms of overall survival with the addition of local radiation to the mix. And this is just their Kaplan-Meier curves that show the benefit, but again, in that subset of patients with low volume disease. And so that made it to the guidelines. So the guidelines recommend that you consider primary radiotherapy in combination with your systemic therapies for these patients with low volume disease. So that's good, but I'm a surgeon. So what about surgery? Should we offer them a radical prostatectomy? And the answer is we don't know yet. So there's several studies in Europe as well as in the US, and hopefully y'all are enrolling in this one too. But it's a little tougher sell than I thought, because most of the patients who present with like really bad metastatic disease also have really bad local disease. And so it's not clear that they're great candidates. But this is a study comparing no treatment to local treatment for all comers with metastatic burden, and then they get subsetted. They sort of a priori decide they're going to want radiation if they get randomized or surgery, and then they flip the coin and they find out what they get. So until we have that type of information, we really don't know whether to offer surgery to these patients, and so it's not a standard by any means, and there's a lot of morbidity to it. So radiation, once again, out in front has a trial, but we don't. So in theory, for newly diagnosed metastatic patients, you may end up in an area where we have triple therapy with giving patients. So if your chemotherapy is not preferred, so maybe they have an ejection fraction that's poor, or they're just averse to getting chemotherapy, then we're looking at ADT plus the oral agents, either abiraterone, apalutamide, or enzalutamide. On the other hand, if they are going to receive chemotherapy, then you can certainly consider adding the additional darolutamide or abiraterone to the mix. And then, of course, possibility if they're oligometastatic of adding local therapy. I didn't really talk because the data is not real good yet on spot welding, low volume oligometastatic disease, although we do it. But the studies are really small, and so they're hard to put a level evidence stamp on. So this patient did pursue radiation therapy for local control, and he tolerated it well, and he continues on his therapy. So take-home messages for newly diagnosed metastatic disease: chemohormonal therapy, certainly a standard of care over ADT alone. And it's hard to imagine so many men dying of prostate cancer in the United States never having been offered chemotherapy, but it happens every day. Um, More potent androgen targeting therapies are certainly options for patients, especially those that are not either low volume disease or not candidates for chemotherapy. And then the triple therapy is emerging. The data looks really good. But again, we have to get some sort of understanding of who would be the most appropriate patients to do that, and understand that it's going to come at a cost, higher amounts of side effects, and we're going to have to monitor them a little better. And then treatment of the primary, we know that radiation therapy for those low volume patients has some data that's good. And we want to continue to enroll in trials for patients with higher volume disease, as well as consideration of the role of surgery. So we got off to kind of a late start on this, and I have more to talk on, but I think that we might want to, cut at this point. And if I need to do some other, I have a whole bunch on non-metastatic CRPC, et cetera. But in the interest of your time and understanding that, I certainly can stop here and answer any questions.
Yeah, you mentioned that this is being revised currently. I'm anxious to see whether or not PSMA PET will become the preferred imaging agent and not how is PSMA PET could be. Because for us, the standard imaging is not very helpful, certainly in
Yeah.
chemical recurrence. So what would Poland guidelines?
So we haven't crafted them yet in the wordsmithing. I think it'll certainly be as equal an option as conventional imaging. I think they're always thinking about what if it's unavailable? What if insurance won't approve it? What if? And so I think they're probably going to have them in equipoise, but I don't know that yet. Uh, Certainly have to be a lot better than what they've had in the past, which is ridiculous.
I just might mention the panel deciding this. When guidelines put recommendations in, the insurance companies tend to pay attention. And with FDA approval, it still amazes me that we have to fight with them based on good evidence.
I agree.
Anything that you do to suggest that it may be preferred if available, wordsmithing like that,
Yes,
may be helpful for it.
I believe it is preferred, and I will, march that forward. But of course, we'll have to, convince others and the statisticians, et cetera. But yeah, I mean, I think it is preferred. And you're right. Like MRI was the perfect example, right? MRI first, and the U.S. was so slow to approve of that prior to a biopsy. And even though there was data, and they would refer occasionally to like AUA white paper, which wasn't updated, and it was harmful. So I agree that the more we can get those into those guidelines, the more likely we will be able to get insurance companies to understand or to approve.
My other question is the use of antagonists versus agonists. What's your approach to using antagonists, and when do you prefer it? And now with the new oral agents,
Yeah.
cardiovascular toxicity. So how are you using those?
That's a really good question. So we are so the HERO study, which most of you know, was oral Regolix, and that was looked at for comparison with LHRH and traditional, and it resulted in faster lowering of testosterone, more sustained. Of course, there were special things built into the study, like a cap that notified the authorities if you didn't open your pill jar and stuff. But it was superior, and then the benefit of it was that it was reversible quicker. So ideally for patients who have like a defined period of time, they're going to be on ADT, 6 months with radiation therapy. Those would be great patients to target. You mentioned the cardiovascular stuff. And in that study, of course, they ferreted out patients, they had to be like 6 months out or more from a major cardiovascular event. And there was a reduction in some of the cardiovascular events, major, in the patients treated with the antagonist as compared to the agonist. However, a larger study, the PRONANCE study, where they used Agaralex, did not have that finding, and the reason might have been because those patients were under the care of cardiologists. So in the PRONOUNCE study, they like had lipids and cholesterol monitoring. We're seeing a cardiologist, and so they didn't see that significant reduction in cardiovascular events. So in my mind, it's sort of like if you know that these medications can impact on the heart and you know that they could worsen it, you should get a cardiology evaluation and be under the care. So there may be some benefit to the cardiovascular, but it's unclear. And so that is a harder sell. But I think all of us would agree that cardiovascular disease is the number one killer in men in America, and getting a heart checkup, monitoring your cholesterol, and being under the care, especially if you're on these agents, is worthy. Um, Getting back to how we do it, some people prefer the pill. They don't want to come into the office. They don't like the shot. The durability of it, though, is one of the things that I consider. If I know I'm going to want to reverse that sooner, of course, that means we almost have to redo all the trials because we don't know, like in radiation, was some of that benefit the hangover effect? Because many of the traditional medicines we use take 6, 9 months or more, and some patients never quite rebound back to their normal testosterone level. But I do think the advantage of the oral agent that's the antagonist is that it's going to be more quickly reversible. How do you do it in your practice?
Pretty much the same way. Pretty much the same.
Cost is different too. So I kind of find that, while there's always some assistance for patients, the shots are billed differently. And so if you do struggle with your daily balancing of your budget, it's going to be probably easier under current situation to receive shots. I guess the cheapest thing would be an orchiectomy, but many men do not opt for that as their initial therapy. But there is a cost consideration to the oral medications too.
As a guidelines reader, as a guidelines writer, oftentimes we see treatment options where there's relative equipoise because maybe there's no head-to-head data. There's unlikely to be head-to-head data in many of these medications. Is that a problem for you as a guidelines writer, as you see maybe some practice variation driving that? And if it is a problem, what level of evidence does the panel look at to push something to the preferred?
Yeah. So they have historically avoided cost. So that's an important thing. Um, where we run into all the problems is usually when people try to compare study A to B and use the side effect profiles in the studies. And that's not fair. So we're constantly having to remind people, like making a table of side effects when they were assessed differently, use different metrics, different times, ask different questions. That's a problem too. But I don't have a great answer except for, need to compare some of these things head to head in order to really see if there's like big differences in falls, big differences in seizure, big differences in fracture rates and things like that. That, the European Stampede model is pretty impressive for how they're able to make modest comparisons. But most of those class medications work pretty similarly, other than little niches around maybe some CNS, um, crossing the blood-brain barrier, that kind of thing. So I don't think that many people, given what we saw in the non-metastatic CRPC, where enzalutamide, apalutamide, darolutamide all resulted in first metastasis-free survival and with longer follow-up overall survival. So I think that most of us believe that they work very similarly. It would be really hard to design a study to show like an overall survival benefit of drug A versus B when they're very similar in class. So then that's really just about comparing toxicity profiles, and insurance can often dictate it too, right? So you might say, for this gentleman, I'd rather him be drug interactions come into play. Pharmacists will alert you, hey, they're on this medicine, it's going to affect this. But barring that, I don't think the guidelines can solve all those problems, but at least give you a nice comparison where it's possible.
What's your view on whole gland ablation in metastatic disease?
Yeah, we have really not done much. I mean, I think it should be studied. Everybody wonders, is that dominant lesion the epicenter for the metastatic deposit and how that affect, presumably that's the value of some of the local radiation, right? So then how focal is focal? And, it would probably be a real subset of patients that had this like dominant imaging detected lesion, whether it's PET and or MRI combined, but it's intriguing. And how will that impact on their overall survival and outcome? I don't know. So I think without data, it's just opinion, right? And so I don't think we have those studies yet. But in theory, I like it. That's probably less side effect profile than radiation to the area.
Questions?
About a 10-minute break, come back, talk about some bladder cancer.
Okay.